Welcome to the last module in this ethics course. Today we're going to talk about access to care when it comes to transplant, organ transplant, and the overall ethical issue of access to care. Should all people have access to health care? And so the ethical principles of beneficence and non-maleficence, patient autonomy, all apply in this situation. And so we, as healthcare providers, are faced sometimes with end-of-life ethical dilemmas. And so we're going to be talking about that. In particular, we're going to be talking about end-of-life issues that result in organ failure and the need for organ transplant. So as you review these slides, be thinking about what is in your textbooks, what is in your assigned readings, what is in your Bible readings, and how would that apply to a Christian perspective, reviewing this type of ethical dilemma? In our text reading, the Johnson book and the Fedler textbooks are two textbooks that I hope that you've enjoyed as you've gone through this course. And I would encourage you to read beyond just the assigned readings, but read anything. In fact, by the end of this course, it would be desirable for you to have read all of these books, these two textbooks. And today in particular, we're going to be looking in Matthew and talking a little bit about the Christian perspective. In our learning objectives, we're going to talk a bit about the ethics of solid organ failure and the transplant process. We're going to look at a case study. And then we're going to evaluate the appropriateness of optimization of donations. So when donors are evaluated, many times the geographic distance between the recipient and the donor makes a big difference in the amount of time. And so this actually impacts how we predict outcomes in transplant recipients. And there's two ways: static cold storage, which is SCS, and normothermic machine perfusion. And so obviously that's not always available in every geographic location in the time frame needed. And then lastly, align the ethical issues that are encountered in the solid organ transplant process. So as we look at the patient's beneficence perspective, we have to be thinking in terms of quality of life and will this organ be best fit to this particular person. And many times in transplant discussions, there are committees that evaluate this, and it's not a simple decision. It's very complex. And so healthcare professionals have to balance and weigh ethical decisions that are life and death decisions. And so it's really challenging. Some of the common causes of multi-organ failure are cystic fibrosis, amyloidosis, hemochromatosis, and oxalosis, and then polycystic liver or kidney disease. Patients with cystic fibrosis that's advanced, they will need a lung transplantation. It's important to remember that the life expectancy plays into a role in the analysis of the patient's appropriateness for transplant. The lung that's transplanted will not have cystic fibrosis, but the rest of the body does. So people with CF will continue to need some form of CF treatment. Amyloidosis is a rare disease, and it's characterized by a buildup of abnormal amyloid deposits in the body. These amyloid deposits can build up in the heart, brain, kidneys, spleen, and other parts of the body. And you can have it in one organ or several. Almost 70% of the people with amyloidosis are men, and some forms are more likely to strike people living with infections or other conditions that cause chronic inflammation. People receiving long-term kidney dialysis are at risk for developing one particular type of amyloidosis, but modern dialysis techniques are making this less likely. And then it can exist on its own, and it can be related to another problem. So there's different types, and some are actually hereditary. Hemochromatosis is actually building up too much iron in the blood, And then oxalosis is too much oxalate in the urine. And so both of these can cause liver and kidney failure that could result in the need for transplant. And then the same is true for polycystic liver and kidney disease. It's not uncommon for people to have multi-organ failure and have to have multi-organ transplants. Heart and lung are very common, liver and kidney less so. Heart and liver, lung and liver, heart and kidney, and lung kidney, all of those are commonly done. Kidney and pancreas is a very common transplant combination in people that have chronic kidney disease or people that have had an issue with diabetes that has then caused the kidney and pancreas both to fail. So these are very interesting organ failure and transplant combinations. You may want to look further at this, especially if you're looking at your career and thinking, okay, I need to know more, and I would encourage you to do that. I'm sure that you remember the movie Titanic. If you don't, you've heard about it, obviously. And when you think about this movie, we think about the relationship between two people, the principal stars of the movie. But there's more to think about. And we're going to talk a little bit about the social determinants of health. In Titanic, you had two people from two classes, Jack, who was poor, and the lady that he pursues is wealthy, and so he is in third class and she's in first class. You probably remember this at the end of the movie, and if you're like me, I wanted to say, Jack, why don't you try to get on the door? But what is really happening is we're wondering about two individuals, and we're really pulling for Jack, and we're not thinking about everybody else that is actually already drowned or is going to drown. This is actually what really happened with the Titanic. This study was done in 1968, and it evaluated the people that died in the Titanic based on passenger class. And obviously, first class women had a mortality rate of approximately 3%. Second class was about 18%. Women in third class, almost half of them died. So the people that were in third class were in the bottom of the boat, and they were there because that was the cheapest fare. But what's really interesting is look at the comparison of children. First and second class was less than 5%, and more than 70% of the children in third class actually perished. So the example of the Titanic really is kind of a study in health inequity. The social determinants of health are mostly responsible for health inequities. They're unfair and avoidable. And so we look at the health status that is seen between countries and the roots that lie within education, fiscal policy, government policies, all the things that impact where you live. There was a study done in Washington, D.C. A few decades ago, and what they were noticing is that poor children, some poor children were actually in the same schools, had much better oral health outcomes, and they were actually able to see a dentist. And when they studied a little further, they realized that the children that lived next to the subway station line were actually getting to their health appointments. But if they didn't live close, they didn't have transportation, and they didn't, because these were mostly latchkey kids. These were kids that left school, went home on their own, didn't have parents to take them to their dental appointments. So these are an example of social determinants of health. So for you that want to be nurses, you would do well to examine the life of Dorothea Dix. She was a nurse advocate. She looked at society and said, how can I change it? What could be different? And so what I would like for you to know is that even though she started out as a school teacher, in her mid-career, she became a nurse. She not only educated herself as a nurse, but nursing really didn't exist. And so she became a modern nursing pioneer. She was especially effective in looking at where people lived, and she looked at some of the prisons, and she was teaching a Sunday school class for women inmates in Cambridge and Massachusetts. And she said, we need to make a difference for people that live in these type of facilities. So she actually went to court, fought battles, and changed things. And so in 1843, she asked the Massachusetts legislature to end the inhumane conditions for the mentally ill. So the focus of her life actually laid the groundwork for us to do institutional reform, and so that people that had disabilities, people that were mentally ill, actually began to receive better care. And so she was very effective at that. You can actually read a lot about her life in this slide. So as you read about organ transplant, and it's actually in section 4.5.6 of your clinical ethics book, and if you have the 9th edition, it starts on page 207. But as you read the case studies, be thinking about how income affects health. Be thinking about those social determinants and how that's an ethical issue. And what should we do? Does it impact access to care? Should everyone have access to care? These are the 4 areas that you can look at under social determinants. There's actually a wiki link reference. But we think about economic conditions. We think about social conditions. We think about the distribution among the population, how that varies depending on what country you're in. And so we look at the influence of heredity. We look at what are group differences in healthcare. All of these can be social determinants for health. This slide is actually taken from a CDC report, and it is based upon looking at children with autism. And it's well understood that autism needs to be diagnosed prior to age 2 to benefit from early intervention. We know that brain plasticity actually is something that can occur early in life, and that if we start doing early intervention, we get lifetime benefit for autism. But the diagnostic age of diagnosis for children that are Hispanic, for instance, it's very delayed. And so many children with autism are not actually diagnosed with autism until well into elementary school. And so we know that this creates disparity. So this is another example of a social determinant. So in today's lecture, we're looking at not just access to care and the ethical issues involved in that. And as you read in your book, Clinical Ethics, you'll read about case studies, and you need to ask yourself some questions. The demand for solid organs far exceeds supply. In the United States, 39,000 transplants were done in 2020. However, more than 107,000 remain on a wait list. So we have a scarce resource. It's not available for everyone that needs it. So non-human donors can also create religious concerns. I also want you to know that this can apply as a dentist. I had a patient one time that was from China, and we were going to do an implant. And prepare for that implant, we needed to place some bone, and the bone, she wanted to know where it came from. It actually came from a pig, and she said, I just won't have the procedure done. So that is patient autonomy. So what are the ethics that are involved in this? We have to look and say, we can't prioritize a person for transplant based upon that they're wealthy or that they have fame. So we don't do social worth as a criteria. We have to recognize the patient's potential for benefit. And so if a person is in an end-of-life situation, there are committees that have to evaluate that. The urgency of need, time on the list, how long you've been on the list. The availability of organs is not predictable. And so people can remain on a list for long periods of time. Avoid discrimination based on sex, race, and status. And then the geographic distance, as we mentioned earlier, from donor to recipient. The next case is actually a case for a girl named Amelia. And her plight came to the attention of the American Academy of Developmental Medicine and Dentistry. Children's Hospital of Philadelphia had actually rejected her based on her diagnosis as having a developmental disability. And in fact, in their notes, it was stated, we don't waste organs on kids like that. That actually was something that was contested and actually made the news, the local news there in Philadelphia, quite a bit. As we look at advocacy, some of the strategies, quality of life can be a subjective bias. We know in this situation, the family reached out to the American Academy of Developmental Medicine and Dentistry. A policy statement was developed. The Centers for Disease Control developed a statement, and professional education curriculum actually changed. The National Council on Disability, which is a federal agency, they actually issued a statement, and then the Philadelphia Inquirer published a story. Children's Hospital Philadelphia, their transplant committee reconsidered, and I'm very glad to tell you that Amelia got a new kidney, and not only that, I got to meet her and her family. And so she was a recipient of one of our awards, and it's been more than 5 years, and she's thriving. These are the guidelines from the American Society of Transplantation. And so you can see that it's a very complex issue. So when we start talking about the different organs, there are different guidelines. It's a lot. But you can go online if you want to look at this further. In summary, UNOS, or the United Network for Organ Sharing, manages the National Transplant List. We all need to be aware that public health policies can change. Private sector partners play a role. They can also create controversy. Example of that is what happened this year with the Houston Hospital Transplant List. Transplant medicine has a complex formula for fairness. It's governed by a medical ethicist. And lastly, all of us as health professionals can be advocates for access for care for all patients with appropriate use of limited resources. So thank you for listening to this course, and I hope that these are lessons that you can take with you in your career. Thank you very much.